Hello everyone. I'm Neeta Krish, studying final year BDS in Chettinad Dental College. So today I'll be explaining about NSAIDs in endodontics. So pain, as we know, it usually arises mainly from inflammation of pulpal and periapical tissues. Prostaglandins are main mediators which play a key role in producing pain and swelling. So to manage this pain, we use non-steroidal anti-inflammatory drugs. Uh, they usually act by inhibiting the cyclooxygenase enzyme, which are responsible for prostaglandin synthesis. So in endodontics, NSAIDs are used pre-operatively, intraoperatively, and post-operatively for effective pain control. So, importance of medical history. It is vital in diagnosis, treatment planning, and prescribing drugs. Some medical conditions that have clinical presentation that mimic oral pathological lesions. Uh, Recent medical history is a very mandatory thing. It also includes the family history because it will be helpful in focusing on relevant inherited diseases like hemophilia, thalassemia, malignant hypothermia, and other things. Uh, it provides awareness regarding drug allergies or allergies to dental products. So, medical conduct conditions that warrants the modification of dental care for treatment. So we should be careful in knowing the cardiovascular, pulmonary, gastrointestinal, renal, hematological, and neurological diseases. In cardiovascular, like high and moderate risk categories of endocarditis is possible. Pathological heart murmurs, hypertension, unstable angina pectoris, recent myocardial infarction, cardiac arrhythmias, poorly managed congestive heart failure. And in pulmonary, chronic obstructive pulmonary disease, asthma, and tuberculosis. Gastrointestinal and renal, end-stage renal disease, hemodialysis, viral hepatitis, alcoholic liver disease, peptic ulcer disease, inflammatory bowel disease, pseudomembranous colitis. And in hematological, sexually transmitted diseases like HIV and AIDS, then diabetes mellitus, adrenal insufficiency, hypothyroidism, pregnancy, bleeding disorders, cancer, leukemia, osteoarthritis, rheumatoid arthritis, systemic lupus erythematosus. Neurological, cerebrovascular accident, seizure disorders, anxiety, depression, bipolar disorders, presence or history of drug or alcohol abuse, Alzheimer's disease, and other like Parkinson's disease, multiple sclerosis, etc. So these history are important before undergoing any endodontic treatment. So consideration for effective 3D pain control. Diagnosis is important, definitive dental treatment and drugs. So first of all, diagnose the pain condition, then deliver appropriate dental treatment, and finally administer the effective drugs. Uh, Pharmacotherapy in endodontics mainly involves like local anesthesia, non-narcotic analgesics, that is NSAIDs, opioid analgesics, corticosteroids, and antibiotics. So according to February 2015 American Association of Endodontics online survey, root canal treatment is a dental procedure that makes American most apprehensive. 56% said root canal treatment would cause anxiety. After that, only tooth extraction and placement of dental implant. Women are more likely than men to say dental procedures makes them anxious, including root canal treatment, tooth extraction, and dental implant placement. However, 2008 American Association of Endodontic Consumer Awareness Survey found that patients who have experienced root canal treatment are 6 times more likely to describe it as painless than patients who have not had root canal treatment. So, as we know, today our topic is about NSAIDs. So, NSAIDs are the major class of drugs for managing endodontic pain. NSAIDs offer anti-inflammatory, analgesics, and antipyretic effects. In 1971, Bain and co-workers observed that aspirin and other NSAIDs block prostaglandin production. These prostaglandins are responsible for pain. So, actions due to prostaglandin, beneficial actions, and shear toxicity. Analgesia. Beneficial action is analgesia, that is prevention of pain nerve ending sensitization, and antipyresis, that is it reduces the temperature of the body, and anti-inflammatory, anti-thrombotic, closure of ductus arteriosus. And shear toxicity is like it has a gastric mucosal damage, bleeding tendency, since it has anti-thrombotic effect, limitation of renal blood flow, that is sodium and water retention, asthma and anaphylactic reactions in susceptible individuals. Classification of NSAIDs. NSAIDs are broadly classified as non-selective COX inhibitors, preferential COX-2 inhibitors, and selective COX-2 inhibitors. Under non-selective COX inhibitors, we have salicylates, pyrazolone derivatives, indole derivatives, propionic acid derivatives, aryl acetic acid derivatives, oxycam derivatives, pyrrolopyrrole derivatives. And preferential COX inhibitors are nimesulide, meloxicam, nabutmetode. Selective COX inhibitors, celecoxib, rofecoxib, valdecoxib. So analgesic antipyretics with for anti-inflammatory actions are para-aminophenol derivatives like paracetamol, pyrazolone derivatives like metamizole and propylphenazole, and benzoxazine derivatives like nifopam. So salicylates, they are aspirin, mainly includes aspirin. It is acetyl salicylic acid. In body, it is converted into salicylic acid, which is responsible for most of its action. So the pharmacological actions includes analgesic, antipyretic, and anti-inflammatory actions. Metabolic effects include cellular metabolism, thus increase especially in skeletal muscles. Adverse effects. At dose 0.3 to 1.5 gram per day, it is an analgesic dose. It causes nausea, vomiting, epigastric distress, increased occult blood loss in stools. And in most important is gastric mucosal damage and peptic ulceration. At anti-inflammatory doses, that is 3 to 5 gram per day, it produces syndrome called salicylism, causing dizziness, tinnitus, vertigo, reversible impairment of hearing and vision, excitement, and mental confusion. Hyperventilation and electrolyte imbalance. An association between salicylic therapy and Reye syndrome has been noted. And the main thing is acute salicylic poisoning. It mainly occurs in children. Fatal dose in adult is 15 to 30 gram, but this dose is lower in children, that which is less than like 15 grams itself. Manifestation include vomiting, dehydration, electrolytic imbalance, acidotic breathing, hyper or hyperglycemia, petechial hemorrhages, restlessness, delirium, hallucination, hyperpyrexia, convulsions, coma, and death due to respiratory failure and cardiovascular collapse. Treatment is symptomatic and supportive. Hypersensitivity and idiosyncrasy, rashes, fixed drug eruption, urticaria, rhinorrhea, angioedema, asthma, and anaphylactoid reactions. So this aspirin is mainly contraindicated during pregnancy, which may cause low birth weight babies. Should be stopped 1 week before elective surgery, any elective surgeries, and should be avoided in diabetics and rheumatoid arthritis, mainly in juvenile rheumatoid arthritis, and in chronic liver disease, which may cause hepatic necrosis, and in patients sensitive and having peptic ulcer, and bleeding tendencies. Avoid in glucose 6 phosphate deficiency individuals. Hemolysis can occur. Should be avoided by breastfeeding mothers. So next, we'll see about propionic acid derivatives. It includes ibuprofen, naproxen, and ketoprofen. Ibuprofen, it is the first member of the class, and ibuprofen considered prototype and has well-documented efficacy and safety profile. Multiple randomized placebo-controlled clinical studies have shown that NSAIDs such as ibuprofen in doses ranging from 400 to 600 milligram provide profound analgesia for inflammatory pain due to endodontic infection. So let's see about their therapeutic uses and adverse effects. Therapeutic uses mainly used in rheumatoid arthritis, osteoarthritis, and other musculoskeletal disorders, and in soft tissues, injuries, fractures, tooth extraction, and post-operatively suppress swelling and inflammation. Adverse effect normally like gastric discomfort, nausea and vomiting, and includes headache, dizziness, blurring of vision, tinnitus, and should be avoided in peptic ulcer patients and contraindicated in pregnancy. These are the dosages for following drugs like ibuprofen, naproxen, ketoprofen, and fluorobiprofen. So next, let's see about selective COX-2 inhibitors. It includes celecoxib, rofecoxib, and valdecoxib. It offered potential for both analgesic and anti-inflammatory benefits with reduced, it has reduced GI irritation. Beneficial effects over conventional NSAIDs is reduced GI damage and occurrence of peptic ulcers. It has less occurrence of peptic ulcer compared to other NSAIDs and do not inhibit platelet aggregation on prolonged bleeding time. And these are the dosages for celecoxib and rofecoxib. For celecoxib, it is 100 to 200 mg twice daily, and dosage for rofecoxib is 12.5 to 25 mg once daily. So concerns is like rofecoxib, it is introduced in 1999, became very popular for osteo and rheumatoid arthritis as well as for dental and musculoskeletal pain, but withdrawn in September 2004 due to high risk of MI and two meta-analysis was conducted by Kearney et al. And Meg Gettiken estimate relative risk of cardiovascular events associated with COX-2 inhibitors. Naproxen was found to have no significant adverse effect on the cardiovascular system. As of December 2011, only celecoxib is still available for purchase, and given the situation, a reasonable alternative NSAIDs COX-2 inhibitors not recommended for treating routine endodontic pain patients. So they're not used routinely for endodontic pain. Aryl acetic acid derivative, mainly diclofenac sodium. It has analgesic, antipyretic, anti-inflammatory actions. It inhibits prostaglandin synthesis and short-lasting antiplatelet effect. Adverse effects is like epigastric pain, nausea, headache, dizziness. Dosage is like 50 mg thrice daily or twice daily. And common combination is diclofenac plus paracetamol. Pyrrolopyrrole derivative, it includes ketorolac. It is a potent analgesic, modest anti-inflammatory and antipyretic activity, equal the efficacy of morphine in most operative pain, but does not interact with opioid receptors and is free of opioid side effects, unlike opioids. And it is rapidly observed after oral and intramuscular administration. And uses is like post-operative dental and acute musculoskeletal pain. And it also reduces pain of migraine and pain due to bony metastasis. That is bone, like cancer in bone or something like that. Adverse effects: nausea, abdominal pain, ulcerations, loose stools, drowsiness, nervousness, fluid retention have been noted. Dosage orally 10 to 20 mg, 6 hourly for short-term management of moderate pain. For acute pain, 20 to 30 mg intramuscular or intravenous every 6 hours. And 2 to 16 years, we'll be giving like 0.5 mg per kg in intravenous or intramuscular. In post-operative dental pain, ketorolac rated superior to aspirin, paracetamol equivalent to ibuprofen. Para-aminophenol derivative, paracetamol introduced. That is mainly paracetamol. It is introduced in 1950. It has a good antipyretic and raises pain threshold, but has a weak peripheral anti-inflammatory component. No significant drug interaction. Dosage 10 to 15 mg per kg. Adults is 0.1 to 1 gram thrice daily. Infants is 50 mg. Children 1 to 3 years, 80 to 160 mg. 4 to 8 years, 240 to 320 mg. And 9 to 12 years, 300 to 600 mg. Uses: over-the-counter drug for headache, musculoskeletal pain, and dysmenorrhea. First choice of analgesic for osteoarthritis. Best drug to be used is antipyretic and can be used in all age groups, including pregnant and lactating mothers. Adverse effects: analgesic nephropathy occurs after years of heavy ingestion, and then acute paracetamol poisoning. Acute paracetamol toxicity occurs in children with low hepatic glucuronidase conjugating ability. If a large dose is taken, serious toxicity can occur. Early manifestation like nausea, vomiting, abdominal pain, and liver tenderness. Lately, hepatic necrosis accompanied by renal tubular necrosis and hypoglycemia progressing to coma. Treatment is gastric lavage is done. Activated charcoal given to prevent further absorption. And then N-acetylcysteine should be infused, followed by the same dose. Alternatively, 75 mg per kg may be given orally every 4 to 6 hours for 2 to 3 days. So NSAIDs in dentistry, mild to moderate pain, paracetamol or low dose aspirin can be used. For post extraction or acute pain, ketorolac, propionic acid derivative, diclofenac, nimesulide or aspirin. Gastric intolerance to NSAIDs, selective COX-2 inhibitor, and celecoxib. And patient with history of asthma or anaphylactoid reactions to aspirin, nimesulide can be given. Post-operative or other acute short-lasting painful condition with minimal inflammation, ketorolac can be given. And pediatric patient, paracetamol, ibuprofen, naproxen have been adequately evaluated. So these are the drug interactions of NSAIDs. Like with oral anticoagulants, it has effects like increased oral warfarin activity, increased risk of bleeding, especially gastrointestinal bleeding. And with lithium, it increases lithium blood concentration, lithium toxicity. Antihypertensive agents, antihypertensive effects antagonize. Hyperkalemia may occur with ACE inhibitors or potassium-sparing diuretics. With digitoxin, inhibition of digoxin and clearance and adjacent digoxin dose as necessary. Phenytoin with ibuprofen or high-dose salicylates increases phenytoin levels, adjust phenytoin dose if necessary. With methotrexate, reduces renal clearance of methotrexate. Antacids with salicylates or naproxen sodium. Salicylate concentration possibly reduced by 25%. Aluminum hydroxide decreases naproxen sodium absorption. Propionexid with naproxen sodium, reduce clearance of naproxen sodium. Aminoglycosides inhibits aminoglycoside renal clearance. Insulin with salicylates possibly decreases hypoglycemic effect with large salicylate doses. Cephalosporins possible increased bleeding risk. And comorbid conditions which aggravated by NSAIDs like peptic ulcer, hypertension, congestive heart failure, renal insufficiency, and hemostatic disorder. Do NSAID drugs mask symptoms of odontogenic pain patient? Many patients will usually medicate with over-the-counter ibuprofen before coming to the dental office. So, in a study, it was demonstrated that 800 mg ibuprofen reduced palpation pain by 40%, percussion pain by 25%, and cold pain by 25% only, with a diagnosis of symptomatic irreversible pulpitis and symptomatic apical periodontitis. Thus, clinicians should ask which analgesics were taken in the 4 to 6 hours prior to the clinical evaluation. So, thank you.